Multiple sclerosis is a disease that most often affects young adults in their 20s to say 40s and beyond. But it can sometimes occur earlier in childhood, and this is a stress on families who have to deal with a child with that diagnosis. Dr. Brenda Banwell will discuss these special problems of children with MS and how the family can help best manage it with them and help them deal with their growing up as a teenager and a young adult.
My name is Brenda Banwell. I'm the Chief of Neurology at the Children's Hospital of Philadelphia. I'm a child neurologist, and I look after children with multiple sclerosis. Today I'm going to talk to you a little bit about what multiple sclerosis means to a child and their family. I'll explain a little bit of the history of how pediatric onset multiple sclerosis came to be the ever-increasing recognized form of MS that we see now across the United States and many other parts of the world. I'll talk a little bit about therapy, and then I'm going to end by discussing some of the exciting avenues for future research and care for children living with MS and for the families, colleagues, peers, other students, and schools that support them. So this story started for me anyway in 1999 when I opened a pediatric multiple sclerosis clinic in Toronto. At the time, the entire literature on pediatric multiple sclerosis took me less than a day to read, and the entire treatment literature was a single story of an 8-year-old boy who had been treated with beta interferon. A lot has changed since then. There are now pediatric multiple sclerosis clinics in over 40 countries, and the International Pediatric Multiple Sclerosis Study Group has over 150 members dedicated to the care of children living with MS. Many of you did not know, perhaps, that MS can start during childhood. The youngest children reported are 2 when they experience their first MS attack, although most of the pediatric onset MS patients present somewhere between 10 and 15 years of age. Several things are important about multiple sclerosis in children. First of all, MS in children is a relapsing remitting form of the disease. Just like in adults with relapsing remitting MS, previously perfectly healthy children and teenagers present with their first MS event. It might be visual loss, like optic neuritis, spinal cord presentations, can be sensory deficits or balance problems, or less commonly, can be a very dramatic presentation with confusion, even coma, and multiple findings on neurological examination. Children tend to have a very high rate of inflammatory disease activity. In English, that means that children tend to have frequent relapses early in their disease, even higher than adults with relapsing remitting MS. On a positive side, however, children seem to respond well to MS disease therapies. With treatment, relapse rates often reduce dramatically, and if my entire pediatric MS clinic were to come in to say hello to you, you would not be able to distinguish them from other teenagers or students or classmates. MS onset in childhood is not associated with early disability in most of the patients. And in fact, one very large study from France suggested that disability in pediatric onset MS patients may not manifest for at least 20 years after the first attack. And that study was before any of the currently available therapies were available. Optimistically, and with good reason to be optimistic, we think the disease course of pediatric onset MS will be even more favorable than that old study done many years ago. So what do we do when we diagnose a child with MS? First and foremost, we have to have a very honest and frank conversation with the child, their parents, and other support members. Children know something's wrong, and no matter how young they are, it is absolutely essential that we have a frank and honest and age-appropriate explanation to each and every patient with pediatric MS. Teenagers are particularly interesting. Many want to know enough about their disease to manage their day-to-day lives, but may not be nearly as interested as their parents in a detailed explanation of the cause of the disease or the various aspects of the disease and what it means for their future. It's important to talk to each patient with as much information as they're ready for and at a pace that they can understand. Importantly, it is also, at least as a pediatric provider, always also important for us to have a private conversation with each of our patients to make sure they tell us the things they're really worried about, which they may not have shared with their parents. At the very beginning of diagnosis, we also talk to the families openly about whose news this is MS is a disorder that affects the entire future of the child and their family. At the beginning, that's a lot to digest. And many kids are not ready for their school, their friends, their relatives, their parents' friends, their old schoolmates to know all about it, at least not until they're ready to tell their story. And helping teenagers and kids learn how to talk about MS with other individuals is a really big part of care. Important in pediatric MS is also the context in which it happens. So MS happens in the developing brain at a time when one of the most important things that kids have to do is learn. And while I mentioned that disability is very infrequent in children with MS, we do see difficulties with school and cognitive performance. About a third of children with MS will get or require additional help in school. We can do this. There are strategies that help kids with MS learn. MS can affect not your intelligence particularly, but it certainly can challenge your memory. It can sometimes make it hard to multitask. If you ask my teenage MS patients what they find difficult, they'll say it's hard to be in a classroom when the teacher speaks too fast, gives too much information, doesn't write any of it down, and doesn't give them guidance on how to order or structure their homework or their tasks. All of those things can be made easier for the patient living with MS. Classroom lectures can be taped. Teachers can provide more notes. Patients can rehearse. Parents can facilitate. And really importantly, kids can understand that they can cope with this challenge provided that they let us know they're having difficulty or we test them to see how well they learn. Let's talk for a moment about treatment. Up until very recently, the standard therapies for multiple sclerosis involved injections. For some injections, they were provided daily. Other injection formulations are once every couple of days, up to 3 times per week. Newer formulations, as many MS patients know, can be given every 2nd week by injection, reducing the frequency of needles. I don't have a single pediatric MS patient who has not said at least once, if not 100 times, that they would prefer not to have needles. I remember one of my first MS patients whose disease started when she was 8, and I remember very clearly the day that she celebrated her 1,000th injection. And that came with a whole host of supports that her family had put in place in order to help her cope with the challenge of frequent needles and what that means to a child's day-to-day life. New therapies, such as oral formulations and some of the ever increasingly powerful MS therapies that are given by intravenous infusion at various frequencies, including one course every 6 months, are now emerging as possible treatments for MS, not only in adults, but also in children. Unfortunately, all of the studies that have so far looked at the safety and benefit of MS therapies have been done entirely in adults. There are now several pediatric multiple sclerosis clinical trials ongoing, which will provide much needed evidence for the dosing, timing, tolerability, and effectiveness of these very exciting new therapies in the context of pediatric patient care. As a member of many of these steering committees, I cannot emphasize enough how exciting it is to see an increasing number of treatment strategies emerge with different ways that each of these therapies work, and with an ever-increasing level of evidence that the benefit of early treatment is sustained for many, many years and hopefully well into late adulthood. Let's talk a little bit as well now about why MS may happen in a child. I get asked that question on the first day that I make a diagnosis of MS almost 100% of the time. My first answer is it's not something the child did, it's not something the parent did, it's not something that they as a family failed to do. MS is a complex disease that involves some what we call host genetic factors or things you're born with, as well as interactions with the world in which you live. MS is more frequent in certain parts of the world, including North America, Northern Europe, Southern Australia, and among the many reasons that that might be the case appears to at least be some association with vitamin D. Low vitamin D levels are associated with a higher risk of multiple sclerosis in adults and children. And one of the many things that we talk about when we're referring to the family of a child with multiple sclerosis is making sure that everybody maintains vitamin D nutrition, through the use of appropriate doses of vitamin D supplements in combination and guidance with their primary care practitioners. Vitamin D is not the only risk factor for multiple sclerosis in children. There is evidence that prior infection with Epstein-Barr virus, a virus that's also been linked to adult onset multiple sclerosis, is much more common in kids with MS than healthy, regionally matched, otherwise healthy youth. What Epstein-Barr virus does and why it might be relevant to MS remains incompletely understood. Certainly at this stage, you cannot avoid normal exposure to viruses in the community, and we are not suggesting that we should be changing the day-to-day lives of otherwise healthy children to avoid normal viral exposures, but a lot of research is ongoing to try to understand why certain viruses may trigger or increase the immune aspects of multiple sclerosis. Genetic factors are also important. MS does run in families somewhat, although the overall familial risk for multiple sclerosis remains low. We thought, when we first started studying MS in children, that perhaps children had more genetic risk than adults. Maybe the reason they present at such a young age is because the genetic factors that drive this disease are more common in the pediatric population, but we have not found that. At this point, one of the most compelling things we have found is if you look at MS clinics in big cities, the pediatric MS clinic population reflect the diversity of the city in which they live. Many pediatric MS patients are first or second generation Canadians in my studies in the past, or have ancestors from parts of the world where MS is rare. This strongly suggests that at least one of the risk factors for this disease relates to those early childhood exposures. A great deal more work is needed to better understand why that's the case. In addition to understanding risk and the why, maybe even more important, they're certainly more important once the diagnosis has already been reached, is what can we learn about each and every person that might guide the best way to manage their disease. If you measure the immune system in children living with multiple sclerosis, just like if you measure it in adults living with MS, it is not the same as what one would expect in an otherwise healthy individual. The balance between the attacking immune cells and the regulatory or policeman immune cells is not normal. MS patients have too many cells that seem to recognize or attack the brain or spinal cord or optic nerve, and not enough of those policeman cells that control that response. Many exciting avenues of research are now exploring how to fix that balance, and whether if that balance is restored to a more normal, controlled immune environment, will that lead to even better MS disease control? Importantly as well, is what can we do to repair when there are areas of brain injury? Conceptually, we think about children as being particularly good at repair. Certainly, if a child has a fracture, they heal more quickly than adults. It's not yet clear whether that's true in the brain, spinal cord, or optic nerve of children with multiple sclerosis, but it is certainly optimistic that our patients have such a low rate of physical disability. Many of my patients are all-star basketball players, swimmers, dancers, performers, artists, and musicians. And they do so with an incredible amount of energy and enthusiasm, and I will say inspire our pediatric MS team every single day. Which brings me to the next thing I wanted to mention, that MS is indeed a community. I have been privileged to see many of my pediatric MS patients grow into adulthood and to see that they become ambassadors for the MS Society and for others living with the disease. One of my patients is, I believe, the youngest MS chapter president in Canada. She had acquired that role before her 21st birthday. My patients have participated in the MS Walk, in bicycling activities for MS fundraising, and in a wealth of other outreach activities to inform other children and youth that they're not alone. One of my youngest MS patients at the MS Walk ran into my family and I as he was walking with his family and looked at me with his eyes wide open and said he couldn't believe that all these people were there for him. And that culture of support starts as early as we can bring our patients to understand it. The MS Society of both Canada and the United States and in other parts of the world have created camps for children and teens living with MS. As a doctor, I was afraid they were all going to go to camp and come back in full rebellion against all of their medications. And in fact, it was the opposite. My patients came back from that shared experience with other children and other teenagers empowered, confident, aware, and part of a new community. And with that came even more ownership of their disease, which ultimately is really the success to keeping patients on the treatments that we believe are modifying the long-term course of this disease. Nothing works if people can't take it or won't take it, and people have to believe that they're taking something that is helping them in the long run. Certainly, talking to others living with MS and sharing that experience and talking about what it's like to have a different teenage life than the other kids in your school really helps a lot of patients cope. I'm going to end by commenting a little bit on research. Among the many, many things that need to be understood about multiple sclerosis, in addition to why it happens and how that might be prevented, are whether or not there are strategies to better enhance repair. How can we help the brain or spine or optic nerve heal areas of injury more effectively, and ideally, of course, have patients on therapies that may prevent those areas of damage from happening in the first place. Up until very recently, most of that work, if not all of it, was done in the context of adult onset multiple sclerosis. I'll pose to you that maybe children will teach all of us some very important information about multiple sclerosis. When MS starts at a very young age, the disease is beginning very, very close to the environmental risk factors that may have driven the onset of the disease. At a time when a pediatric MS patient has yet to experience other irrelevant exposures that cloud our ability to figure out what matters and does not matter in the cause of MS in adults. And at a window of time where we have this opportunity to potentially dramatically turn down this abnormal immune response before the brain suffers significant injury. That drives all of us as pediatric MS researchers to work harder, to better understand the children we look after, to invite them to participate in research as a member of the big pediatric MS community, and very importantly, to collaborate. Happily, MS is rare in children, but that rarity makes it all that much more important that research, clinical care ideas, and outcomes are shared across all of the pediatric MS centers and programs worldwide. The MS societies have played pivotal roles in allowing that to happen, and meetings like the consortium bring all of us together so that we can share what we've learned and make sure that we optimize everything we do for these incredibly inspiring patients that we look after.